I said, I'm going to be sharing my perspectives on the management of hormone receptor positive, HER2 negative advanced breast cancer. And I'd welcome questions at any time point, and hopefully we should have a very interactive discussion. These are my disclosures. So as you know, metastatic breast cancer actually formulates a really huge landscape. About 20 to 30% of patients who have early stage disease will eventually develop metastatic breast cancer. And we have about 4 to 9% of patients that actually present with breast cancer up front. These are stage 4 de novo patients. However, this data actually does come from North America and Europe. And I believe, at least in our part of the world, Middle East and Asia, I think the percentage of stage 4 de novo may be slightly higher. And as you know, patients who have metastatic breast cancer can either be hormone receptor positive, HER2 positive, or triple negative. And the largest cohort of patients are actually those with hormone receptor positive that constitutes about 60% of the patients that we see in the clinic in the metastatic setting. Now, even amongst these patients who have hormone receptor positive disease, they have a spectrum of the way that they present. At one end of the spectrum, you have those patients that have rapid disease progression, extensive visceral involvement. They're basically resistant to all modalities of therapy. And this is where you give them chemotherapy. At the other end of the spectrum, you have those patients that have a very long, indolent course of disease, where their disease will just be very, very, very slow growing over a long period of time. And that's where we tend to use endocrine monotherapy. And it's that gap in between where we use combination endocrine therapy with either mTOR inhibitors, CDK4/6 inhibitors, and as you know, we now have PIK3CA inhibitors as well, such as alpelisib. Now, just taking a step backwards, the way that we used to treat our patients in the first line setting in patients with metastatic breast cancer, hormone receptor positive, we used to be able to give them tamoxifen, and this was associated with a progression-free survival of approximately 6 months. We then shifted to aromatase inhibitors because we know it was associated with an improved progression-free survival of approximately 14 months. We then saw the results of the Falcon trial that took patients who were endocrine naive, first-line therapy, hormone receptor positive, and randomized them to receive either fulvestrant or the aromatase inhibitor anastrozole. And what you immediately tend to see is that in terms of the primary endpoint, in terms of progression-free survival, fulvestrant did trump anastrozole, with the progression-free survival improving from 13.8 months to 16.6 months. But more interestingly, when you stratified based on whether or not they had visceral disease, you can see amongst those without visceral disease that there was a significant improvement in the progression-free survival from 13.8 to 22.3 months. And amongst those patients with visceral disease, there was practically no difference between giving either fulvestrant or anastrozole. We then saw the results of the SWOG trial that looked at the combination of fulvestrant plus an aromatase inhibitor. And what you essentially see is that you're not really improving the progression-free survival by that much. However, it's important to actually look at the combination of fulvestrant plus an AI in terms of the SWOG 0226 trial, because it did teach us some important lessons. So just to take you a step back, the SWOG 0226 trial took patients first line setting and randomized them to receive either anastrozole or the combination of anastrozole plus fulvestrant. In terms of progression-free survival, I showed you that already, but more importantly, after a follow-up of about 7 to 8 years, that's where you were starting to see an improvement in overall survival of about 7.8 months. And what essentially this trial showed us was several important lessons. The first was an improved progression-free survival does impact your overall survival, and that sequential endocrine therapy is not the same as using your best combination in terms of endocrine therapy upfront. So before the introduction of CDK4/6 inhibitors, this is the way that we used to sequence, the way that we used to treat our patients with endocrine monotherapy. In the first line setting, we used to give a combination of aromatase inhibitor or fulvestrant. That would be associated with a median progression-free survival of between 14 to 17 months. In the second line setting, you could give either exemestane or fulvestrant, depending on what you used in the first line setting, and that would give you a progression-free survival of about 4 to 6 months. And in the third line setting, you would use tamoxifen. And with the use of this sort of a schema, you were getting a median overall survival of approximately 50 months. The question was, could we in fact do better? And what we saw with the introduction of CDK4/6 inhibitors such as palbociclib, ribociclib, or abemaciclib, when you combined it with an aromatase inhibitor in the first line setting, you are now improving the progression-free survival from 17 months that you got with fulvestrant all the way to 28 months. This was associated with a hazard ratio of 0.55, which essentially tells us that when you use combination endocrine therapy with a CDK4/6 inhibitor plus an aromatase inhibitor, you were reducing the risk of progression of disease by approximately 50%. And if you wanted to be able to treat your premenopausal women, you had to render them postmenopausal and then give them this combination therapy, and that's where you would get the best progression-free survival. Now, this is some real-world data of using CDK4/6 inhibitors. This real-world data comes from the Flatiron database that is from the United States between 2015 and 2018. And what you can see in terms of the use of CDK4/6 inhibitor, which is the blue bars, you can see over time this has increased. In terms of chemotherapy, which are the red bars, you can see it has decreased over time. And in terms of endocrine monotherapy, you can see it has in fact decreased over time, but still a significant proportion of patients are still receiving endocrine therapy as a monotherapy upfront, really telling us that community oncologists still believe that there are certain subgroups of patients that all they require is endocrine monotherapy in the first line setting. And we can actually have a discussion about that later on. Now, I think one of the most important points when you're looking at your patient and trying to treat them in the clinic, you need to understand is that endocrine sensitivity does matter when you're trying to plan your strategy. And what you see over here, these are patients who have either stage 4 de novo disease or recurrent breast cancer. And you know that patients with stage 4 de novo breast cancer, they have no prior exposure to endocrine therapy, so they're essentially endocrine naive. They have the best responses, the best progression-free survival when you give them endocrine therapy. In patients with recurrent breast cancer, if they relapse early within the first 2 years, especially if they're still taking their adjuvant endocrine therapy, you can see that these are the patients that have primary endocrine resistance. If they relapse between 2 to 5 years, and if you've continued that endocrine therapy to 10 years, which is what we typically tend to do now in the early stage setting, these are patients who have a secondary acquired resistance. And if they relapse post completion of their adjuvant endocrine therapy, they have endocrine sensitive disease. And differences in endocrine sensitivity will influence the outcome that you have for your patients when you are treating them. Now, in those patients who are already metastatic and you're treating them with multiple lines of therapy, you also have to understand that with each line of therapy, biology changes, targets tend to change, and new targets tend to emerge. We know that resistance develops to the endocrine therapeutic agents, and we know that response to future endocrine therapy will depend on the response to previous endocrine therapy. And that is something that we really need to think about when we're treating our patients in the clinic. So what I thought I would do is I would work through a couple of case examples to really highlight some of the nuances that we need to think about in the clinic when we're trying to treat our patients with hormone receptor positive, HER2 negative metastatic breast cancer. And one of the first questions that comes up is, in the upfront setting, are CDK4/6 inhibitors associated with a survival benefit? So this is the first case. This is a 36-year-old pharmacist. She is premenopausal, single. She has no children. In November 2019, she presents with a right breast mass with palpable axillary lymph nodes, and biopsy reveals an ER/PR positive, HER2 negative disease, and PET-CT shows extensive liver, lung, and bone metastases. And you can see this from the MRI here. The liver is practically studded with disease, and her liver function test is 1.5 times the upper limit of normal. Now, some of the issues to think about in a patient like this is that, are you going to give chemotherapy or are you going to give combination endocrine therapy? And if you decide to give combination endocrine therapy, is there a survival advantage by using a CDK4/6 inhibitor? And if you're going to use a CDK4/6 inhibitor, what would be the optimal endocrine therapy partner that you're going to give with that CDK4/6 inhibitor? But I think going first is the question is this patient in visceral crisis? Because I think when you see that MRI and you see the liver studded with disease and the liver function is slightly deranged, this is a question that typically comes up. Now, in our multidisciplinary tumor board, we discussed this case and we decided that this patient was not in visceral crisis because although there was a slight disturbance, it wasn't a major disturbance in that liver function of that patient. So then the question that came up in our multidisciplinary tumor board was, what were we going to consider as optimal first-line therapy for this patient? Were we going to give chemotherapy, or were we going to give endocrine therapy alone, or were we going to give endocrine therapy plus a CDK4/6 inhibitor? And these were important questions that we asked because, again, that liver, although we didn't consider this patient was in visceral crisis, was studded with disease, and the liver function was slightly disturbed. So we want to be able to pick and choose a therapeutic option that would give us a rapid response and a maximal response for that patient. Now, in terms of a CDK4/6 inhibitor, we know in an endocrine sensitive cohort, and I'm saying that this patient actually has endocrine sensitive disease because remember, this particular patient has stage 4 de novo disease, has not been subjected to any form of endocrine therapy in the past. So in the endocrine sensitive cohort, we know from PALOMA-2, MONALEESA-2, and MONARCH-3, these were 3 similarly designed clinical trials that took patients in the first line setting, randomized them to receive either an aromatase inhibitor or an aromatase inhibitor plus a CDK4/6 inhibitor. And you immediately see that there is an improvement in progression-free survival, very nice separation in the Kaplan-Meier curves. But more importantly, that improvement comes very early on when you give combination endocrine therapy. But more importantly, going back to my case, remember that liver was very, very studded. So you want a rapid response, and the knee-jerk reaction would be to give chemotherapy. And when you compare giving combination endocrine therapy to single agent chemotherapy, we know from the CLGB 40502 trial that when you give Taxol single agent in patients with metastatic disease, you get a response rate of about 38%. But in patients who are getting combination endocrine therapy, and this comes from the MONARCH trial, when you give them a combination of abemaciclib plus an aromatase inhibitor, and if they have liver metastases, you can get responses of up to 57%. So I would say either it is very similar to giving chemotherapy, if not better, in terms of attaining those high response rates. So going back to my patient, we did decide we were going to give combination endocrine therapy. So the second question we ask ourselves, is there a survival advantage to using a CDK4/6 inhibitor? And the simple answer to that is yes. We have 2 trials, the MONALEESA-7 trial and the MONALEESA-3 trial, both very well conducted phase 3 clinical trials. In the MONALEESA-7, it randomized patients to either getting endocrine therapy alone or endocrine therapy plus ribociclib. And in this particular trial, they used either tamoxifen or an aromatase inhibitor, and all patients were actually premenopausal, so very young women who'd been rendered postmenopausal. In MONALEESA-3, they randomized patients to getting either fulvestrant or fulvestrant plus ribociclib. Irrespective, both trials showed a 30% reduction in the risk of death from disease when you added a CDK4/6 inhibitor. Now, one of the questions that repeatedly comes up is, why was MONALEESA-7 and MONALEESA-3 a positive study in terms of overall survival, yet PALOMA-2, which used palbociclib, has not read out in terms of overall survival? And I think the simple answer to that question is that these were very, very different in terms of the cohorts of patients that were enrolled in the trial. You can see from MONALEESA-7, I told you these were all premenopausal women. They were very young. 43 years was the median age of enrollment in this study. And you can see that younger women do actually have more aggressive disease. So you will see some early results Plus, in this particular trial, you can see that 14% of patients had actually received prior chemotherapy before enrollment, really suggesting it was a very bad cohort of patients with very aggressive disease. In the MONALEESA-3 trial, it was a true first-line endocrine-sensitive cohort. They used fulvestrant instead of an aromatase inhibitor, and no one was allowed to have a DFS or disease-free survival of less than 12 months, while in PALOMA-2, 20% did have a DFS of less than 12 months. So again, a very different cohort of patients. So then the next question comes, what endocrine therapy partner are you going to use with that CDK4/6 inhibitor? And the question to this came up because are we going to use fulvestrant, or are we going to use an aromatase inhibitor? And this year at ASCO, we did see the results of the Parsifal trial. This was a phase 2 clinical trial that took fulvestrant plus palbociclib or letrozole plus palbociclib. 86 patients enrolled in this trial. Median age was 63 years, and 60% of these patients had stage 4 de novo disease, and 50% had visceral metastases. And what you immediately see from the Kaplan-Meier curves, this was the primary objective of the study, progression-free survival. You can see there's practically no difference between the cohort of patients who received fulvestrant plus a CDK4/6 inhibitor or aromatase inhibitor plus a CDK4/6 inhibitor. And what I take away from this trial is that you could use either fulvestrant or an aromatase inhibitor in combination with a CDK4/6 inhibitor in the upfront setting. So coming back to my case, she was considered not to be in visceral crisis, and we commenced her on abemaciclib, goserelin, because remember, she is premenopausal, so she got Zoladex. We gave her letrozole and denosumab. Now, one of the questions that repeatedly comes up is we have 3 different CDK4/6 inhibitors. We have palbociclib, ribociclib, and abemaciclib. How are we going to pick and choose those 3 CDK4/6 inhibitors? Well, in terms of efficacy, they are exactly the same. But in terms of toxicity, these are the differences that you can see. There are differences in neutropenia, diarrhea, thromboembolic events, reversible transaminitis, and QTc prolongation. And you'll have to really look at the type of patient that's in front of you in the clinic, whether they're elderly or they're patients with cardiovascular disease, or these are patients with hepatic impairment or multiple comorbidities. But overall, palbociclib and ribociclib, they have predominant bone marrow toxicity, while abemaciclib has predominant gastrointestinal symptoms and a less pronounced hematological toxicity. Coming back to my patient, we did start her, as I told you, on a combination of CDK4/6 plus an aromatase inhibitor, and you can see immediately her CA15-3 started to decrease when we gave her treatment, and you can see that her MRI pre-treatment, her liver was completely studded with disease, and by March 2020, she had attained a very good partial response, and she continues to be on treatment. Now, one of the questions that comes up, and I mentioned this briefly right at the very beginning of the presentation, is that in the upfront setting, are there subgroups of patients that you may perhaps consider not giving an upfront CDK4/6 inhibitor? Does everyone actually need a CDK4/6 inhibitor in the upfront setting? Well, we do have the results of the FDA pooled analysis of approximately 4,200 patients, in which you can see that irrespective of the different stratification factors such as PR positive or negative, DFS, whether patients had de novo disease or not, or whether they had bone only or liver lung metastases, the hazard ratio is exactly the same. And whether they're young or younger than 40 or over 40, they're still having the same benefit from the addition of CDK4/6 inhibitors. But despite the fact that you cannot tease out who should and should not, because everyone seems to be benefiting from CDK4/6 inhibitors, certain subgroups actually benefit more than others. And so this again comes from an exploratory subgroup analysis of patients enrolled in the MONARCH-3 trial. And what you immediately see is that when you give an aromatase inhibitor on its own, these are the percentages in terms of response based on these different factors. The minute you add a CDK4/6 inhibitor, you can see that the percentage response or overall response increases significantly. But the patients who actually benefit the most in terms of that increase in response rates are those patients who have the most most bad prognostic part of their disease. That means they have liver metastases, they have PR negative disease, they have high grade disease. So essentially, those patients, everyone benefits, but those patients who have bad prognostic factors tend to benefit more. Are there any biomarkers that could help us predict for sensitivity to CDK4/6 inhibitor? And this is a very crowded slide. It comes from ASCO 2020, where there was a pooled analysis of the MONALEESA-3 trials, really trying to look to see if there are any biomarkers that could predict for response to ribociclib. And I will just very snapshot view, there weren't any specific biomarkers that could help predict. There were some that predicted for increased sensitivity, some that predicted for resistance, but nothing that you could use clinically in the clinic. Now, this was a very interesting trial that was presented at ASCO 2020. This was the PADO-1 trial. I found this trial to be extremely, extremely interesting, and a very interesting design of this trial. This was a first-line trial for patients with metastatic breast cancer, hormone receptor positive, HER2 negative. All of these patients were sensitive to an aromatase inhibitor, and they were all given an aromatase inhibitor plus palbociclib. And what essentially the authors did was that they tested for ESR1 mutation, and as you know, ESR1 mutation predicts for resistance to aromatase inhibitor. They tested for it at baseline, and then they continued to test for it at 1 month and every 2 months. And those patients who had a rising ESR1 mutation were re-randomized to receive either continuation of an aromatase inhibitor plus palbociclib or fulvestrant plus palbociclib. Now, this part of the trial wasn't reported, but the authors did report the first part of the trial. And what they showed was that if you had an ESR1 mutation at baseline, you tended to have a worse prognostic outcome. And you can see the median progression-free survival was 11 months for those that did not have a baseline ESR1 mutation, and about for those who did have an ESR1 mutation, it was 11 months. But for those who did not have an ESR1 mutation, it was about 26.7 months. So it does predict for a worse prognostic outcome. But then what happens to that ESR1 mutation when you actually give aromatase inhibitor plus palbociclib? And what they essentially showed was that the ESR1 mutation can actually clear, and about 23 of the 33 patients enrolled, their ESR1 mutation actually cleared. And then what they did was they went on and they looked at the prognostic outcome amongst those that had cleared their ESR1 mutation versus those who did not clear their ESR1 mutation. And amongst those that did clear it, again, better prognostic outcome, a PFS of 24.1 months versus those that did not clear their ESR1 mutation at 7.4 months. So again, it did show that ESR1 mutation was in fact a biomarker that could predict for worse prognostic outcome, but they did not tell us whether you should be continuing that combination or not. And it's only the second part of the trial when it's reported that can actually tell us whether we need to change that endocrine therapeutic agent as a backbone. The next question we ask ourselves is, could fulvestrant be enough amongst patients without visceral metastases? And remember, right at the very beginning of the presentation, I actually said that in the Falcon trial, amongst patients who had bone metastases or no visceral metastases, PFS was actually very good at 22.3 months. But we also know that the combination of letrozole plus CDK4/6 inhibitors amongst patients without visceral metastases can be approximately PFS 30 months. And we've also shown from the MONALEESA trial that fulvestrant plus CDK4/6 in the first-line setting can give you a PFS of more than 33 months. So at least from cross-comparison of clinical trials, it does seem to show that even if you don't have visceral metastases, adding a CDK4/6 inhibitor improves prognostic outcome. But as you know, cross-comparing clinical trials is not the best thing to do. And this year at ESMO and in October, we saw the results of the FLIPPR trial. This is a phase 2 clinical trial that randomized patients. Everyone got CDK4/6 inhibitor in the first-line setting, but they randomized them to receive either palbociclib plus fulvestrant or palbociclib plus an aromatase inhibitor. And they randomized patients to receive either palbociclib plus fulvestrant or fulvestrant plus placebo. And you can see immediately that when you added a CDK4/6 inhibitor, you are having an improved progression-free survival of 31.8 months versus 22 months. And if you substratified based on whether patients had visceral metastases or no visceral metastases, you were seeing a very good improvement in progression-free survival when you added fulvestrant to palbociclib. So again, even if you don't have visceral metastases, there's a tendency to say, let's just use fulvestrant. You can see now we have a phase 2 clinical trial that's telling you add a CDK4/6 inhibitor because the prognostic outcome will improve in these patients. So in the absence of any clinical trial data apart from the FLIPPR trial, which we have phase 2, but it was still a small clinical trial, it doesn't cover every aspect of the clinical types of patients that we see in the clinic. I still believe that when you're looking at your patients in the clinic, you need to look at the disease-free interval. Those patients, say, suppose with low volume disease, non-visceral mets, low grade, less aggressive biology. We know that adding a CDK4/6 inhibitor will benefit these patients. However, the absolute benefit may not be the same as in those patients who've got aggressive disease. So this could help you pick and choose who should and shouldn't get upfront CDK4/6 inhibitor. This is a second case. It's of a 60-year-old woman who in 1998 actually presented with a T2N0 breast cancer. She was treated with chemotherapy, surgery, and tamoxifen. Unfortunately, in 2017, she presented with back pain, and we found that she had bone metastases. It was biopsied, and it was the same biology. And the question is, what are you going to do at this stage? Is it going to be chemo, endocrine monotherapy, or endocrine therapy plus a CDK4/6 inhibitor? At that point, we gave her radiation therapy and we gave her fulvestrant only. This was a decision of the Multidisciplinary Tumor Board, and we also had issues with her insurance, so we couldn't add a CDK4/6 inhibitor at that time. She did well until January 2019, at which point she had progression in one bone metastatic lesion. And so we decided just to radiate that lesion and continue with fulvestrant. This is something we typically tend to do when there's progression in only one spot. And she did well until September 2019, when she presented with progression both in the bone and now with the development of a new liver lesion. So at this point, what would you do? We could give her either chemotherapy, endocrine monotherapy, but switching it, or giving her combination endocrine therapy in the form of a CDK4/6 inhibitor. So we had actually the results at that time of the TREND trial. Now, the TREND trial was a very, very interesting study. It was a study in which patients were given endocrine therapy. They then progressed on that particular endocrine therapy. The endocrine therapy was not changed, and patients were randomized to receive either the same endocrine therapy plus palbociclib, or the endocrine therapy was stopped and they were continued on, or they were randomized to receive palbociclib alone. And what you immediately see is that there is some good activity with palbociclib single agent. You can see a clinical benefit rate of 60%. But more importantly, when you looked at the combination of giving palbociclib plus the same endocrine therapy agent that the patient had progressed on, you can see that there is a progression-free survival of approximately 10.8 months, something very, very similar to what you see with PALOMA-3. So this is exactly what we did. We continued fulvestrant, which was the endocrine therapy that she had progressed on, and we added palbociclib. And she actually did well until May 2020, when she had progression of her disease. And at that time, we switched her over to aromasin plus everolimus. Now, does first-line setting only pertain to endocrine-sensitive cohort? The simple answer to that question is no. We do have patients in the first-line setting that also have endocrine-resistant disease. And this takes us very nicely into the third case. This is a 34-year-old lady. She's premenopausal. She's married. In September 2016, she presents with left breast inflammatory breast cancer. And as you know, inflammatory breast cancers are very aggressive breast cancers. Biopsy shows invasive ductal carcinoma, ER+PR positive, HER2 negative. She has node positive disease. She receives adjuvant chemotherapy. She receives adjuvant radiation therapy. And then she's commenced, based on the results of the SOFT and the TEXT trial, she's commenced on goserelin and exemestane. Unfortunately, while still on therapy in January 2019, she presents with rising tumor markers. And you can see here very nicely on the scan, she has multiple liver metastases. So some of the issues that you need to think about here is, does this woman have endocrine resistant disease? Should we give her chemotherapy versus combination endocrine therapy? And again, is there a survival advantage to using CDK4/6 inhibitors in the endocrine resistant setting? Now, in terms of whether she has endocrine resistant or endocrine sensitive disease, you can see that she has relapsed while taking adjuvant endocrine therapy. It is on the borderline of either primary resistance or secondary resistance because it's exactly at 2 years, but nonetheless, she has endocrine resistant disease. And as you know, the biology does change in patients who've got endocrine resistant disease. And this is a very nice paper that was published in Cancer Cell in 2018 that has a very nice pictorial diagram showing that patients who have endocrine sensitive disease, they do have certain subclones that can confer resistance. And as you give them endocrine therapy, these subclones tend to grow, and that's how endocrine resistance emerges. About 18% develop ESR1 mutation, about 9% have abnormalities in the MYC pathway, about 13% have abnormalities in the MAP kinase pathway. And the question then comes is, could evolutionary tracks actually influence the choice of subsequent therapy? And the simple answer is yes. And just to focus on these Kaplan-Meier curves, you can see that when you have some sort of mutation or abnormality in those ESR1 or MAP kinase pathways, and you give an aromatase inhibitor, you tend to do worse if you do not have a mutation. But if you give a surge therapy like fulvestrant or other members of the same family, you can see that it doesn't matter whether you have a mutation or not, you tend to do similarly. So again, it does influence the choice of endocrine therapy that you're going to use. Now, in the endocrine resistant setting, when I'm sitting in the clinic and I have a patient with endocrine resistant disease, these are the 3 clinical trials I'm going to think about. The BOLERO-2 trial that looked at the combination of exemestane and everolimus, the 3 CDK4/6 inhibitor trials that looked at the combination of fulvestrant plus CDK4/6 inhibitor, and of course the SOLAR-1 trial that looked at patients with PIK3CA mutation positive disease and gave the combination of fulvestrant plus alpelisib. Irrespective of what you're looking at in terms of clinical trial, when you use combination endocrine therapy, you get a 5 to 7 month improvement in progression-free survival. And this is what you see from the 3 CDK4/6 inhibitor trials in the endocrine resistant setting, PALOMA-3, MONARCH-2, or MONALEESA-3. When you give combination endocrine therapy with CDK4/6 inhibitor, and all 3 trials used fulvestrant, you get an improvement in progression-free survival. But you also get an improvement in overall survival, and we've seen that in PALOMA-3, where there is an improvement of 6.9 months, although not statistically significant, but clinically meaningful. The results of MONARCH-2 also showed an improvement in overall survival, 9.4 months improvement, and MONALEESA-3 showed an improvement of 7.7 months in terms of improving the overall survival. One of the questions that I keep repeatedly being asked is, why was PALOMA-3 not statistically significant, but there was an improvement in numerical number? And again, I go back to the type of patients that were actually enrolled. And the types of patients that were actually enrolled in this study were a very, very heavily pretreated cohort. You can see about 33% had actually received prior chemotherapy versus no one having received chemotherapy in the MONARCH-2 and MONALEESA-3 trial. So PALOMA-3 had a population that was very heavily pretreated, but nonetheless, when you look at those hazard ratios, you can see a class effect, 30% reduction in the risk of death from disease. So for me, at least, it doesn't make a difference which CDK4/6 inhibitor you use. So this patient has primary resistance. We've seen that. I showed you from the pictorial diagram. We know that there is a survival advantage to using CDK4/6 inhibitor in the endocrine resistance setting. And just to give some very nice nuances that came from MONARCH-2 and PALOMA-3, because I think each of these clinical trials, although using different CDK4/6 inhibitors, the fact that they had different patient enrollment or the different types of cohorts enrolled in each of those trials, I think each of those trials teaches us something. And you can look at PALOMA-3 and MONARCH-2. If you look at their primary resistance cohort, in PALOMA-3, there was no difference in terms of adding CDK4/6 inhibitor in the primary resistance cohort, but there was a difference in terms of improvement, 7.2 month improvement in overall survival in the primary resistance cohort. But when you look at the clinical trial properly, you can see that the definition of primary resistance here was very different from the definition of primary resistance here, where in PALOMA-3, it was a heavily pretreated cohort of patients. When you're looking at secondary resistance, again, PALOMA-3 and MONARCH-2, there was a benefit in terms of improvement of patients in terms of their overall survival. So it doesn't matter if it's primary resistance or secondary resistance, CDK4/6 inhibitors work. Now, interestingly, as I told you, the third trial is SOLAR-1 trial, which looked at patients with a PIK3CA mutated positive cancer, hormone receptor positive. You know that the trial looked at patients giving a combination of alpelisib plus fulvestrant versus fulvestrant alone. We know from Fabrice André presented this data a couple of years ago at ESMO, showing that when you gave alpelisib plus fulvestrant in the endocrine resistant cohort, there was a nice improvement in progression-free survival. This year at ESMO, he presented the results in terms of overall survival, and you can see that there was a 7.9 month improvement in overall survival, although this was not statistically significant, but again, in my mind, clinically meaningful. And when you look specifically at patients with lung or liver metastases, there was a 14.4 month improvement in overall survival. So again, a very nice drug, but the question comes up is, what are you going to use? In a patient with endocrine resistant disease and PIK3CA mutation, are you going to use alpelisib or are you going to use a CDK4/6 inhibitor? Well, in my mind, the simple answer is you give a CDK4/6 inhibitor, then use alpelisib. For the simple reason, when you look at the overall response, it's higher with a CDK4/6 inhibitor. There's been longer duration of follow-up with a CDK4/6 inhibitor. In terms of progression-free survival, we've seen the longest progression-free survival of 17 months with a CDK4/6 inhibitor. And in terms of overall survival, it's been statistically significant with CDK4/6, and it is not significant with alpelisib and fulvestrant. So I think in terms of sequence, I would first use CDK4/6, then alpelisib. So this particular patient was given abemaciclib, goserelin, fulvestrant, and denosumab. She had a complete response by April 2020, and she currently still is on therapy. My last case is a very interesting lady, actually. She's 70 years old and she presented with a stage 4 de novo disease. She had a few lung mets. We put her on Arimidex. She was on Arimidex for 2 years. And then she comes back to me with significant progression in her liver as well as in her pelvis. She could hardly walk. And if you saw her liver function test, it was all over the place. She was clearly in visceral crisis, but she categorically refused to receive chemotherapy. At that point, we decided to give her fulvestrant plus palbociclib, and you can see within 2 cycles, she had a dramatic improvement. Her pain disappeared, her liver functions improved, which brings me to the next question. Is it time to be more flexible in the definition of visceral crisis? Are there any differences between the three CDK4/6 inhibitors? In my mind, in terms of cost, maybe this is different in different regions of the world, but in terms of efficacy, absolutely not. In terms of progression-free survival, approximately 45% reduction in the risk of progression of disease. In terms of overall survival, approximately 30% reduction in the risk of death from disease. In terms of ease of administration, yes, there are differences. Ribo and palbo is 3 weeks on, 1 week off, while abema is continuous dosing. In terms of toxicity, yes, I showed you that. And in terms of monitoring, yes, there are differences. And in my last couple of slides, it's not only about endocrine therapy and it's not only about CDK4/6 inhibitors and alpelisib and Afinitor. We are actually going to see some other targeted agents emerge that we're going to incorporate into the treatment of patients with endocrine-resistant, hormone receptor-positive, HER2-negative metastatic breast cancer. One of those agents is a PARP inhibitor in the form of olaparib or talazoparib, because we know patients who have germline mutations from the Olympiad and BRCA trial, when you randomize them to receive either a PARP inhibitor or physician choice of chemotherapy, PARP inhibitors trumps physician choice of chemotherapy. We also saw from the Plasma Match trial that when patients have ESR1 mutation, extended dose of fulvestrant did have a benefit. We've seen patients who acquire a HER2 mutation. You can give them a combination of neratinib plus fulvestrant. And of course, there is the emerging targeted therapy to AKT mutations, and this is capivasertib. And we're going to see some nice data that's going to come out at San Antonio this year that's using another AKT inhibitor, which is going to be very interesting in terms of using it in patients with hormone receptor positive disease who are endocrine resistant. So finally, this is the algorithm that I follow in my clinic. In patients who've got endocrine sensitive disease, we tend to give them a CDK4/6 inhibitor plus an aromatase inhibitor up front. We then test for the PIK3CA status. If they're mutant, they will get alpelisib plus fulvestrant. If they're wild type, they'll get fulvestrant either alone or in combination with everolimus. And then when they progress, we test for those other targets like BRCA or HER2. And then when they progress on that, we then give them chemotherapy. In our endocrine resistant cohort, we ask the question, has a patient received prior CDK4/6 or not? In those that received prior CDK4/6, they go through the same algorithm that I've just shown you prior. In those that have not received a prior CDK4/6 inhibitor, we ask the question, do they have primary endocrine resistance or secondary endocrine resistance? If they have secondary endocrine resistance, they go on to receive CDK4/6 plus endocrine therapy, and then the rest of the pathway is similar to what I've already shown you. If they have primary endocrine resistance, we ask ourselves the question, has the patient been heavily pretreated in the past with multiple endocrine agents, multiple chemotherapeutic agents? Because those patients, like PALOMA-3 showed, there's no real benefit to adding CDK4/6, and you might want to consider some novel agents or chemotherapy. But if they've not been previously heavily pretreated, that's where we consider CDK4/6 inhibitor plus endocrine therapy, as in what we saw in the MONARCH trial. So that's it for me. And again, thank you for the invitation. I'd be happy to take any questions. Thank you.